141 is infected of 4 million, according to this model. And that gave us an effective reproductive number of 2.09. And if you know the mechanisms of the reproductive number, it has to be 1 and below for the epidemic to stop. But this is still 2.09. So one person effectively will infect 2 other persons that are susceptible, and the epidemic continues. And the doubling time, as predicted by this model, is 6.7 days for this state, which means it will take roughly 7 days for the total number to double in this state. But there's something interesting from this graph. If you noticed that this model predicted that between the last and the 3rd week of June, the epidemic will meet its peak. It will peak and start to decrease, as you can see by this blue line, in terms of the number of admissions recorded in the hospitals. So we are hoping that by the last week of June, that this epidemic will peak, not just in these states, in Nigeria, and probably in Africa. We are still working on the model, but there's a lot of uncertainties in the model, I must also warn. How has the social impact, what is the impact? How has it helped? I tried to show this particular diagram to give you an idea. We've been monitoring how people have been moving within Nigeria and within that particular state. We noticed that this is actually gotten from the Google Community Mobility app. You can all check it up. It's on the internet, it's on the web. Just type Google Community Mobility app, and you will see how people are moving in your own environment. In Gambia, you will see how people are moving, how people are responding to restriction measures and so on. Now, this particular comparison compares social mobility with respect to February values. So this is a relative comparison. So in Nigeria, and in this particular state of Edo, when the school was closed, you noticed that many more people started staying at home. It increased. This is in response to residential area. Many more people started staying at home. When Nigeria decided to lock down the country, it only locked down 3 states. And this particular state was not part of the 3. You notice that in countrywide, on average, many more people stayed at home, but in the states, it didn't have much effect because the lockdown was not implemented in that state. And you also notice that when Nigeria decided to reopen the states, many more people stopped staying at home and it keep on dropping, and they started going back to work and other places. But in this particular state, everything still remained constant. They were not affected by the lockdown because they did not implement it. And we also noticed that these particular states that were locked down in Nigeria witnessed a lot of social unrest. But these other states did not witness social unrest because people were in partial lockdown, they could still move about, go about their socioeconomic life and so on. So this is actually telling a huge story on how public health measures can affect socioeconomic life and even civil liberties. I'll beg to skip this slide. It's similar to the first one, but this time it's in respect to the workplace mobility. I'll just skip it. So at this point, I want to conclude my presentation by saying that COVID-19 is new, yes, we know, but epidemiology is not new. So an epidemiological measures can be deployed whether you actually know the full story about any pathogen. Epidemiology works at any given time. The burden of COVID-19 is huge currently in Africa. Containment and mitigation remains key to its control. Sub-Saharan Africa seems to be the last continent to witness the pandemic. However, control measures should be titrated against socioeconomic realities in Sub-Saharan Africa. So at this point, I want to say thank you all for listening and having me. And I want to say thank you to Musa for inviting me. Thank you, everyone.
Thank you very much, Dr. Greg. Thank you for the presentation. Now we welcome questions and comments as we also get Mr. Singate on board. Questions and comments, please, from Dr. Greg, please.
Hello?
Hello, Musa.
Yes.
Yes, I have a question, please.
Please go ahead. Thank you.
Yes.
I want
My
to ask.
question, thank you for the presentation. My question was on the social physical distancing question. You actually
Yes.
said you will get back to it, but you didn't. So can you just clarify how that will help, especially we are moving out of the quarantine, the emergency lockdown period, and people are going back to business as usual. So how would that help us on preventing a spike? Thanks.
Oh, thank you very, very, very much. And um, I decided to skip it a little bit because of time, since there's another presentation, but I'll just dive into it very, very briefly. Social distancing is part of the mitigation measure. What social distancing actually does is to decrease transmission and number of cases, okay? And there are two types of social distancing: individual social distancing and community social distancing. Individual social distancing deals with the individual trying to protect himself and also trying to protect others from himself by ensuring that you keep 1 meter from the next person, hand washing, personal hygiene, isolation, self-isolation if you notice any symptom, use of face mask, and so on. All those play into individual social distancing. Community social distancing, on the other hand, has to do with actions that are taken at the community level in terms of closure of public places like schools, religious homes, and so on, and then closure of bars, restaurants, markets, and all that. So all these closures or movements in terms of curfews or reducing the number of passengers in buses, all these are community social distancing. What they do is to make sure it breaks the transmission from one person to another. And if that happens, what generally now happens is that the number of people who are infected and present to the hospital are reduced. And our hospitals are able to cope with those who will come down with severe cases, the 2% that will come down. So that's actually what social distancing does. And it is now being advocated because now have drugs and we don't have vaccine. But the problem here is this. Social distancing also means that people cannot go about their livelihood. People cannot feed, they can't go and fend, they can't go to work. And we all know that more than 70% of the workforce in Africa is informal workforce. These are people who rely on feeding day to day from their work. Apart from that, we also know that close to 200 million people in Africa are below the poverty line. In fact, almost 100 million alone in Nigeria. So restricting them from moving also means that you are having another problem, which is hunger. And if you look at the Sustainable Development Goal, number 1 is to curb hunger. So if we are having this mix, how do we balance it? How do we titrate it? This is the whole issue here. What may have worked in Europe, where you have welfare states and social backup from the government, may not work in Africa. In fact, in Africa, there are some circumstances you cannot even implement social distancing because people live in slums. So in that case, what can we do? So what we advocated initially was intermittent social distancing. You close down the state or the country, you assess the situation, you go ahead with screening, you go ahead with isolation, and then treatment. That's what, and then after assessment, you find out that the number of cases is dropping, you reopen the state. That's called intermittent social distancing, so that people can go about and fend. However, if you must close down the state, what is being advocated is you don't close down things where places where people can go and buy food. basic places like markets, shopping centers. You don't close down agricultural activities. However, in such instances, you preach individual social distancing and hold back community social distancing. But key to managing this in such instances is screening and isolation, testing. And I showed that particular table that looks at how many people have been tested per country, where South Africa was. So all these are the impact of social distancing, especially in Africa. And this is what we are preaching, that you should either do an intermittent social distancing or focus on individual social distancing, but increase or heighten your ability to screen, isolate, and test, and treat. If you can do that, and you monitor the data coming out based on confirmed cases and deaths and all that, then you can be able to titrate socioeconomic life with the pandemic outcomes. I hope that responds to your question.
Yes, that basically responds. But if I'll just add a small extra to it, is in the context of social distancing, in the absence, do you advocate for universal mask, usage of universal mask? That will be the last thing, please. If you can comment on that, thanks.
Oh, sure. Sure. Evidence have shown that these masks do work, even when you do it with the normal fabrics. The masks actually work. So yes, we'll actually advocate for that. That is a key component of individual social distancing, actually, use of face masks. Yes, we'll do that. So anytime someone is in public, put on your mask. I will surely advocate for that. In terms of breaking the transmission.
Thank you very much.
You're welcome.
Thank you, doctor. All right. Yeah, this is your student Amadou. Yes, I just want to pick up from where Musa stopped with respect to the moderation. It seems they are having some connection issues. This is one of the questions raised by one of the members, and he is interested to know that he said some experts argue that Africa has not performed more tests per capita compared to the rest of the world. Does this argument hold water? What is your reaction to this particular question, Doctor? Before I move on to the second question, just to make it very fast, since the second
answer is
presenter
yes.
is also
The answer is yes. The answer is yes. We haven't performed more tests compared to. If you check the number of tests per a million people, Africa still lags behind the world. And you can see that data in the worldometer coronavirus page. And Africa is far behind in terms of the number of tests. In Nigeria, we only have 333 people tested per million, 333 per a million in Nigeria. So that's very small. That's very, very small. So yes, and it's actually true. And one of these slides actually spoke to that. If you check this particular slide here, if you notice this second to the last column is tests per 1 million population. This is Nigeria here, number 3. Per a million people, it has only tested 346. Look at Sudan, 9 per a million people. This is very low. And if you check, let me look at Gambia. Gambia is even higher than Nigeria. Gambia has tested 777 per a million people. So compared to the other countries of the world, Africa is still very low.
Thank you so much. Thank you so much. This is explicit.
Sorry, Ahmed, Mr. Barrow.
Yes.
Yes, I just have a quick question because I'm rushing out.
Okay, thank you. Go ahead.
Yes. First, I would like to thank the doctor for that presentation. And my question is, of the opinion that something could have been done, at the initial stage when the whole thing was an outbreak, meaning before it becomes a pandemic, right down at China. So I want to ask the doctor, was there anything that could have been done to prevent this that was not done at the initial stage of the outbreak?
Yes, yes. Thank you so much for that question. That's a brilliant question. And that is the importance of this particular slide here that looks at the timeline. I brought this up deliberately. And this is what has, this is where the issue came up. First of all, there was an issue that China did not provide the necessary information to the WHO as expected by the International Health Regulation Policy. That is one. However, as at the time WHO started getting the information, by January 9th, even when the first case was observed, WHO did not still admit that human-to-human transmission is possible. If they had admitted at this time, control measures would have begun by January 9th. But they had to wait almost 3 weeks before they declared it public health emergency of international concern, knowing that it can spread from human to human and across states and countries. That delay, that 3 weeks window that we had would have saved a lot of lives and would have actually slowed down the epidemic. And if you look, January 27, WHO actually admits an error that they did not assess the risk properly of the virus. These are huge landmarks, really. And epidemiologically, you know, we already know what to do as soon as we notice a new condition. If you follow the triad, which I showed, we know what to do. So this delay actually was detrimental to management and control of the disease. So we would have actually started informing countries, mounting all the measures necessary epidemiologically to restrict it to China before it spread. Unfortunately, that was not done, and we have this pandemic in our hand. Thank you.
Thank you so much, Doctor. I think we can take one more question. It seems Ibrahim Abaro was going to ask us to why Africa is not seeing most of the cases around the continent, if there are some scientific explanations to that. And in Doctor's opinion, while in your attempt to answer the previous questions, in fact, part of that question has already been answered in my opinion. However, this is a very important question that I still choose among the whole. That is, economists and other development experts have argued that extended lockdown will significantly hurt already struggling economies.
Yes.
How can we create the right balance, safeguarding the public health versus avoiding severe economic consequences as a result of the ended lockdown? I don't know what's your reaction to that, Doctor. And finally, if there is a causal argument that one of the factors responsible for low fatality in Africa could be for the youthful population. If you can respond to these two, Doctor, quickly, we will now call on the next presenter. Thank you.
Thank you very much, Hamidu. And like you said, it's straightforward. Africa, the median age for Africa is 18 years, which simply means that 50% of Africa are below 18 years. 50%, that's huge. And if you take that number to 45 years, it will be almost 75% of African countries. 5% of the population are below 45 years. Have shown that severe cases are unlikely in this age group.
All right, this is excellent. And for some other questions,
severe cases are most likely in elderly people.
Okay, sorry. Okay. Go ahead, Doctor.
Thank you.
All
so,
right.
And in addition to this, Africa is not known for flu. Don't forget, coronavirus actually flu-like. Africa is temperate and is emerging that could be a protective factor in itself, the climate already existing in Africa. But on the other hand, scientists are also saying that probably it could be to underdiagnosis and lack of testing. That is why we are not seeing cases. So that argument is also being put forward. But holistically, the population is helping. And then with respect to this socioeconomic stuff, I've already said earlier, we have to titrate it. We have to, what we are preaching now is intermittent social distancing, not lockdown. If you lock down Africa, then you dip the continent into economic disaster. So we are advocating for intermittent lockdown, or in some cases, just a partial lockdown so that people can move and go about their businesses. You can lock down some very high risk sectors like religious organizations, sporting activities, and all those stuff, because they are contacts and they are highly, they can increase the transmission in those settings. But anything that will really impact on the economic life as preached by the African CDC, we have to be cautious about it, and don't lock those areas down. Schools and other means of livelihood, agriculture, markets, shopping centers. No, we shouldn't. So that's what we are preaching: intermittent or partial lockdown.
Oh, thank you so much. Thank you so much. Doctor, I hope you will stay with us for the next presenter, after which maybe some of the, let's say, audience would want to have a follow-up questions, or some of the questions that they weren't opportune to be raised. I think we can, if you will be online, would be appreciated. And of course, we're also looking forward to have you for another conversation this